Now, what I thought was we'll be starting this first course here, which is the Phaconightmares course. The idea here is this, very simple. We want to make this interactive and so that you can all learn more and more. All of you, get your seat belts fixed, fix glue. This is going to be a roller coaster, okay? So the first presentation what I thought I'll show you is the longest 2 days. And it's very nice that we have Dr. Richard Packard, Rohit Om Prakash, and Namrata will be joining us here. So this case you can see here was a case of pseudo-exfoliation and NS3 type of cataract. I thought, let me start my phacoemulsification. So this is day 1, ladies and gentlemen. Okay? I start my rexes, and when I start my rexes, I complete it, no issues. I just start my phacoemulsification, and you can see what's happening there. I am just started. I've not done much. Somewhere, some mistake, gone. Now you can imagine how my heart sinks. At that time, I thought of one person, and his name is Richard Packard. And luckily for us, he's sitting on the dais right now. Because, let's see this in slow motion first. In slow motion, look at this. I've not done anything, and I'm gone. Okay? Question is, can I retrieve it? Richard was the first person to teach the world a technique which is posterior assisted levitation. He published this with David Chang, and Kelman also had worked on this. But the first person who's really started this PAL technique was Richard Packard. Now, this was the first paper which they had published. So what I thought was, I used the pars plana trocar. I'm fixing it where it has sunk inside. We published this, a modified PAL technique with scaffold and glued IOL also in the JCRS in 2017. Now look what I've done. Once I've got my trocar fixed, I'm going to bring this nucleus anteriorly up. I'm using 2 hands. In one hand is my chopper. In my other hand is the rod. The prime aim is what? You need to bring this nucleus anteriorly. So let's look at it on animation. I'm bringing the nucleus anteriorly up with my vitrectomy probe. Once it is up, simple, all of you, use a 3-piece IOL. The principle is, put the IOL above the iris, but behind the nucleus. So this works like a scaffold. In other words, you have created your own posterior capsule. Once you have created your own posterior capsule, then you can keep one haptic above the iris, one haptic outside. You can put both haptics inside. Call is yours. You can put into the sulcus also the IOL. But either way, the principle is simple. Without batting an eyelid, the phaco will remove the nucleus pieces. So here you see now, the nucleus is above the iris. So where is my IOL, ladies and gentlemen? It is between the nucleus and the iris. Okay? And this we published in the ophthalmology in 2013, as you can see, where we published the IOL scaffold technique. So this is the second technique I'm showing in the same video. I showed you PAL. Now I'm showing you the IOL scaffold. So the IOL is there. I don't have any fear of this nucleus falling down. Once my nucleus is out, now dilate. Because please understand, I do not know how much rexus I have. I do not know where my capsule is. I do not know where my cortex is. So once I dilate, now you see I'm going to dilate that pupil with iris hooks. Now I've got fluid in the eye. I have a sulcus. I put my IOL into the sulcus. Now I go in, and with my vitrectomy probe, I can very comfortably remove all the cortex. Look at the capsular bag. It's sublux there. That was the reason why this whole nucleus must have gone down. Now, either way, once everything is done, now I take out my iris hooks. But look, once you have dilated this patient with the iris hooks, vitreous was there, everything was there. Invariably, many cases, the pupil will be distorted. So what you have to do, learn the simple technique called the single pass 4th-row pupilloplasty. So once I'm removing it, I'm now going to do the 4th-row pupilloplasty. So those who have attended the morning course of mine have learnt it, but those of you who haven't, very simple thing, all you need to do is, I'll use this pointer here. Look from the top, pass the needle, proline needle, okay? All of you, pass it through the clear cornea, comes through the iris from this side. Here you have a paracentesis. Remember, paracentesis is only in one side. Actually, this is your main port of the phaco. Pass a 26 or a 30 gauge needle inside, railroad these two. This suture will come out like this. Once the suture comes out, see, I've railroaded it, brought it out, okay? Now I bring this loop out, and we publish this, you can see in the European Journal of Ophthalmology in the year 2017. All you do is then fix that thing and complete it. Now once you have done that, I then saw day 2. So I'm seeing my patient on the second day. Look what happens. Pupil is okay, but IOL is decentered. Oh, my heart sank. Same patient, remember, this is not the second patient, okay? Now, the cornea is bad, so what do? I scrape off the epithelium, and now I know I have to shift to a glued IOL. Remember, I always put a 3-piece IOL in such cases, because if you are in trouble, ladies and gentlemen, you can always convert. So, to a glued IOL. Now watch, I made my flaps, shifted my hands from one hand to the other. So remember, you need this handshake technique. In a handshake technique, look at my finger here. If I need to catch the tip of the haptic and pull out. So remember that. If I catch it anywhere, transfer it from one hand to the other till you catch the tip of the haptic. Once the tip of the haptic is caught, catch it and pull it out. So far, so good, but no, it's slipped. The haptic has slipped. Why? Something wrong somewhere with my surgical hand. I prefer to say something wrong with the instruments to make my heart much better. But invariably, it's something wrong in my surgical hand. Now look at it, what I'm doing. I'm trying to catch the haptic. I catch the capsule. Gone. First day, nucleus drop. Second day, IOL drop. What does it show? It shows I should stop operating. You can't see a worse surgeon than me in the entire planet. Imagine the same patient, I drop the nucleus the first day, and the second day I drop the IOL. I'm showing it to you in slow motion, gone. Now my IOL is gone. I fix my trocar. I do my vitrectomy anyway some more. Now a technique which we started was started by Ashwin called the sleeveless extrusion canal levitation of the IOL. And we published it in the BJO, British Journal of Ophthalmology 2014. The principle is simple. After your vitrectomy, you're going to use the cannula to lift that IOL up with suction. Once it comes anteriorly, we'll shift to the forceps and externalize the haptics. So you see, I put my IOL there lying on the retina. I put my SSV lens there. Using a suction, look at that, it's just lifting it up. Very safe technique. Now once it has come anteriorly, I'll shift to the handshake technique. Remember, you need 2 forceps, ladies and gentlemen. You can get these forceps dime a dozen from any company, I don't know, in the stalls there. I have no financial address. But one trick I tell you, if you're buying 2, buy 1 straight and 1 curved. You'll be much better off. Because sometimes you need a curved and sometimes you need a straight. So when you're buying 2 for a handshake technique, don't buy both straight or both curved. Keep 1 straight and 1 curved so that depending on what situation you want, you can always do it. This is the one which we published in the JCR, is the handshake technique, transferring haptics from one hand to the other. The idea is simple. I need to externalize the haptics, create the chariot's pocket, tunnel, and externalize. See the haptic stuck there, got the haptic there, once externalized. You see, my next step is going to be, I will create the chariot's pocket there and tuck inside. This is the glued IOL which we first published there. Once that's done, now check. I had done 4th-row pupilloplasty which I showed you. do you have optic capture? So ladies and gentlemen, simple trick. How do I know whether I have got optic capture or not? Inject air in the anterior chamber. If injecting air does not show optic capture, there's no optic capture after injecting air, this patient will not have optic capture. So now, once that's done, all I need to do is, I know there is no optic capture there. Already my photopupillasty is done. I need to just apply the fibrin glue, seal everything down, post-op 1 week, vision improved to 6/9. So look at that. First day, we had the nucleus drop. Second day, as you can see, we have the IOL drop. Then 1 week post-op, vision has improved to 6/9. Those in the back, please, there are few seats in the front. Please come and sit down here, okay? You'll be more comfortable. So, if you prefer the Yamane, you can do the Shin Yamane's technique, which is a brilliant technique which Shin has brought out. I prefer the glued IOL for a simple reason, ladies and gentlemen. Though the Yamane technique is very good, you see there's a bulb on either end. And so, since the bulb is there, there'll be a little bit of tilt. You have to accept that. The second problem, and I was talking to Harminder Dua just now in the morning, is, remember these 3-piece IOLs are manufactured handmade. It cannot be just like a machine, like a single piece. So when you take a needle and tuck the haptic into the needle to pull it out, sometimes it pulls out, and you get these complications like rotisserie. So before I move to my next case, which I thought I'll ask some few comments from Richard on the scaffold technique and on Rohit on the glued IOL techniques. Richard? Microphone.
Oh, it is. Right, okay. Scaffold technique is very useful. Years ago, I used to do something similar with a sheets glide, but sheets glides are not so readily available. The important thing you want to do is to separate the eye into different compartments so that you've got the pieces of nucleus available to you, so you can easily phaco them, but you also don't want to have the possibility of them dropping back. Now, interestingly, we're talking about the PAL technique. I first described that, but it wasn't called the PAL technique then when I wrote a book on cataract surgery with my wife, which was published in 1991. It was Charlie Kelman who actually gave it the name that it did. An alternative approach to getting things up, if the nucleus hasn't dropped too far, is viscote levitation. And the advantage of viscote levitation is, one, you're not putting an instrument in the eye, but it also gives you a barrier underneath, and you can phaco on the top of it, because being a dispersive viscoelastic, it doesn't come out. And David Chang and I wrote that up also. But I think the scaffold is very useful. I've certainly done this in the past. And you've got to be careful, as I'm sure Ray will mention, you've got to control the lens once you've done everything else.
Yeah. So, this is a very important point which Richard has mentioned. You have compartmentalized the eye. It's not just removing the nucleus. Okay, yes, no doubt about that. You've safeguarded your nucleus, everything. But remember, when you compartmentalize, the IOL is there, so you separate the vitreous from the front. So what will happen is that extra vitreous which is in the back is not going to come in the front out anteriorly. So one of the biggest advantages of IOL scaffold is the compartmentalization which Richard talked about. So we'll talk on one more topic, the glued and the Yamani, the pros and the cons of both the techniques. Yeah. And I'll ask Rohit to comment, and then we'll move to the next video.
I think the biggest challenge with all these lenses is the tilt which we have. And because with Yamane, when you are going transconjunctival, you are not sure whether and how much you are flanging. Why do you still prefer, how are you able to control the tilt in the glued IOL?
It's a very good question. So what we do is, suppose you have a large eye. Please understand, all these 3-piece lenses are 13 millimeters. When you have a large eye, you need to come more anteriorly, because if you come more anteriorly, more haptic is tucked. That's the basic principle. Okay? So I make a small iridectomy at the peripheral area where the scleral flap is, so that I come more anteriorly. The glued advantage is I tuck, untuck till my lens is bang centered. I will see that there's no astigmatism, or really negligible astigmatism. We published a paper in the ophthalmology journal, that is the main journal of AO. We got about a 1.5 degree tilt on anterior segment OCT after 5 years. Please understand, a lens in the bag will give you about that much only. Okay? A lens in the sulcus will give you 5 degree tilt. So you can imagine how safe and stable these glutathione are. Now we have done past 17 years or 18 years since we brought it out. So let's move on to the next video, and I'd like Richard and then Rohit to talk to us on it. This video is called Potpourri. I'd like people in the back can come in the front. There are some more seats here, okay? So this patient had a desmase detachment during phaco. Now the doctor called me up and he said, listen, please help me. I'm in big problem. So I said, no, send the case over. No problem. I will make it all right. Little do I know, and little does he know also, when I say such things, you know how my problems will increase only. So the nucleus is left behind, okay? So now let's see how this patient is basically. This is the anterior segment OCT of that patient. There's a desmase detachment. Nucleus is there. Look at the space between the iris and the cornea. There's really no space, actually. But now I say, okay, I've told him I'll fix it. I inject trypan blue. I can't see anything. So I'm taking off my epithelium. Look at that. When I injected the trypan blue, you can see the desmase very clearly. Now, Susan Jacob had started telling me this ACE technique where I'm injecting air continuously to push the detachment back. I closed up the suture of the bad incision which was made. I make a fresh incision and I start my phaco. Now look what's happening. When I'm doing my phaco, my DM, desmase, is fluttering. When my desmase is fluttering, my heart is also fluttering a lot. So now what happens? In this fear, when it flutters, I feel that desmase is getting sucked into the phaco probe. When it happens, see what I do. Stupidly, I pull out. Oh! When I pulled out, the desmase also came out. I told you I should stop operating. Simple. But no, I will continue. See, entire desmase has come off now. End block. So now what I say, okay, I'll put a 3-piece IOL inside. Now, I say I'll do the 4th row pupillasty, which I taught you about just now, and I've done it. So now, I'm doing the other side, 4th row pupillasty, to make my pupil smaller. Now, you know what? Slight cortex is there, as you can see there. Okay? So I thought, okay, what I do? Let me try to remove that cortex. I'm trying to remove the cortex. Now, in the end, somewhere my IO probe has got into some capsule. Now, when that has happened, I'm wondering what's going on here. So now, let's see what happens. IOL is tilted. Now, immediately when the IOL is tilted, obviously I've created a rupture. Now, what did the previous surgeon do? He created a desmase detachment, that's all. What did I do? I removed the entire desmase. Now I removed the entire capsule also. With that, the entire vitreous also has come off. Now my IOL is sinking again. You must be thinking, Arey Baba, how many IOL does this man sink? So now I make my flaps. So you see now I'm making my scleral flaps. I've got my fluid now shifted to that side. Now remember, I've done a 4th row pupillasty. Now I have to break it. How do I break it? I put my iris hooks. So first I do a pupiloplasty. Now I'll break the pupiloplasty also. So now I'm breaking the pupiloplasty. Once that's done, now you see, I'm going to make my sclerotomy here. Now I go in with my vitrectomy probe and I'm removing all this mess which is present there, clearing it all off. Once everything is cleared, now what will we do? Handshake technique. I already showed you the handshake technique. So transfer the haptic from one hand to the other till you catch the tip. Catch the tip and pull out. So far, so good. First haptic out. Now you go ahead, catch the second haptic. So now you see I'm going to catch the second haptic, catch the tip, pull out. Okay? Once both haptics are out, now look. Now I go ahead and create the chariot's pocket. Look at the amount of haptic externalized. It's a lot. Remember that. I come anteriorly. Don't go 2 millimeters behind the limbus. The amount of haptic externalized will be very less. You will be in trouble. So now, once both haptics are tucked, now you are much safer. Now what do I do? Single pass, 4th row, pupiloplasty. I did the pupiloplasty. I broke the pupiloplasty. Now I have to redo the pupiloplasty. But remember, what did I tell you? Clear cornea goes through. Here you need a paracentesis. This needle will go through the paracentesis and railroad the two. Now watch. Now what happened? You have to go through the paracentesis. By mistake, that 26 or 30 gauge needle has gone through my corneal tissue here. So watch now. Now when I railroad, I bring it, I'm now trying to pull both. When you pull both, it should be in the center. But look, the suture has come to the, knot is coming to the edge. Obviously, now I've gone through the tissue. So what do? Cut again. Again redo. Now what I did? I created an iridodialysis. Look at that. He didn't have. The patient just had a desmase detachment. I removed his desmase. I created his capsule rupture, removed the capsule, removed the vitreous. Now I've also removed his iris also. So now, ladies and gentlemen, how do you fix an iridodialysis? Let's watch. Okay, I've created an iridodialysis here. Now, whenever you are fixing an iridodialysis, if it is here, the simple way is fix a trocar opposite the iridodialysis. This is the trocar-assisted iridodialysis. There are dime a dozen techniques for iridodialysis repair. But I tell you honestly, try this. It'll be the easy. I've done them all. But this is the safest technique. Now what you do is pass a double arm needle through this. The idea of the trocar is what? Basically, this is a modification of the hangback technique of Michael Snyder. So the idea here is what's simple. In this, I'm passing the needle through that, comes out through this. Now I'll do the same on the other side. You see me doing just now. Once both are done, all you need to do is pull. And you'll see me just pull at both ends. That repairs the trocar-assisted iridodialysis. So look, I'm fixing it. See how badly traumatic I have made this iris. It was not so bad when I started. Okay, I have messed it up. Totally my fault. Now what I'm going to do is pull. Now, ladies and gentlemen, look at me. When you pull the iris like this, remember, you have fixed the iridodialysis. But be clear, you have distorted the pupil. Okay? So if you see in the picture here, this iridodialysis is repaired, but this pupil has got distorted. So what you have to do? Now you have to do a photoreopuplasty. This is the twofold technique. In other words, you're combining the trocar-assisted iridodialysis with the photoreopuplasty. So once this iridodialysis is repaired, so I'm showing it to you in animation. See, I'm fixing the iridodialysis, okay? My pupil has got distorted. Now what you do? Do the photoro. So this is the twofold technique, and we publish this also in the JCRS. Here you see, once I've done the twofold technique, I'm combining the trocar-assisted with the photoreopuplasty. So look, I did the trocar-assisted. Now I'm doing the photoro. Now look at the Purkinje image P1. That's important. Invariably, sometimes that pupil will get smaller. When it gets smaller, don't get worried. Now use your vitrectomy probe. Make it slightly around the Purkinje image so that you're bang on track. And you can see me doing that just now. So you can see here the vitrectomy probe, using that till my Purkinje image. Look at the P1. This is P1. Ladies and gentlemen, look at this P1. Now look at this inverted one. That is P4. Do not focus on P4. Remember, we have 4 Purkinje images. P1, P2, you don't see P2 at all, so forget about it. P3 will be very large, so don't worry about it. The main thing is the confusion will happen between P1 and P4. So the simple way to remember is the P4 is inverted, the P1 is not. This will be slightly blurred and slightly faint also. But anyway, once that's done, case not over. Remember, ladies and gentlemen, I had removed the entire desmase complex. So we do this technique of PDEC, or pre-desmase endothelial keratoplasty, just on a completion's sake. You're looking at the endothelium now. This, what you're seeing is I've turned the cornea upside down, create a bubble. So this bubble has desmase, endothelium, and the Duas layer. We don't do DSEC and DMEC. The reason is very simple. In PDEC, we use young donors, and you will not get detachments. In PDEC, by and large, we get 3%. A DMEC will give you something like 20 to 30% detachments. But that's another story we'll talk about. Inject the trypan blue, stain, dissect the graft, inject it inside. Ladies and gentlemen, let us see now how this patient did. So you can see this is closer. Now you can see the post-op. Pre-op, you can see how the patient was. This was the anterior segment OCT I showed you. And post-op, the vision improved to 6/9. So when I move to the next video, I'll ask Richard and Rohit's comments on iris repair, because I think today, iris repair is one of the most important things which everyone in this hall has got to understand, because you have pinhole pupiloplasty, which will solve astigmatism, cosmetic, mydriatic pupils, photophobia, etc. So what is the technique, Rohit, you tend to use when you are doing iris repair?
I think as far as the iris repair is concerned, within iridodialysis, the trocar assisted is the one which I usually use, because that we published a technique for bag IOL complex fixation also with the trocar, so that takes care of that. With the so many pinhole pupilloplasties were there ever since, but with single pass 4-throw pupilloplasty coming in, that has made life easier. And with the corneal abrasions around, and in patients who have trauma with paracentral or linear scars, we have been able to create a situation wherein the corneal grafting has been delayed in so many patients, and we can do a pinhole pupilloplasty as well in those patients.
Richard, your comments on the iris repair, Richard?
I think your iris repair has actually changed a lot of people's lives. It's very simple. We all had the CIPSA technique before, which was fine, and you've adapted that and demonstrated that a 4th row is actually a knot that will not slip. And I think that's the critical thing.
Thank you very much, Richard. So, ladies and gentlemen, let's move on to this next case, okay? I tell you what, after this Phaconightmare course, you know what? None of you will be attending any more courses of mine. You say, this guy creates so many complications. This guy is absolutely mental. Look at this patient. This patient came to me from Iraq, okay? This was a lady who was sent from Iraq to Iran for phakic IOLs. So the surgeon there put an anterior chamber phakic oil. Subsequently, the patient developed all these complications. So you have endothelial decompensation, cataract, peripheral anterior synechiae, and closed angle glaucoma. A top ophthalmologist from Iraq, he called me up and he said, I'm sending this patient, VIP patient to you. I said, okay, no problem. I will make all right. Okay. And you know how it goes subsequently. So let's see how I manage this case. I take off the epithelium. This is an anterior chamber IOL, okay? Look at this patient. She has peripheral anterior synechiae there. You can see that it's stuck on anterior segment OCT. So what I do, now I say, okay, let me first bisect this IOL. So here you can see I'm bisecting this IOL, taking a scissor, cutting it. Once that's done, you can see I've taken out one piece. Now I'll take out the other piece. Okay, so far so good, both out. Now look, there's a membrane there. The mistake I did was this. Obviously there's a cataract, no doubt. I thought that's just a membrane. I didn't realize it's also a capsule, and I tried to rip it off fully with a forceps. And with that, you see, I created some mess inside. Because when I go in for my phaco, I notice I can't find the anterior capsule. And what's happening is, when I go in for my phaco, I've used my iris hooks, and I'm putting my 3-piece IOL, there is a rent. Look at my IOL, it's sinking. Remember, patient has come all the way to me from Iraq. Okay? VIP patient. I don't know what to do. Now I know my IOL is sinking, so I make my flaps, I make my sclerotomy. Now again, as I've taught you before, I will do the vitrectomy, and then I'll do the handshake technique. So you see I'm catching the haptic from one hand to the other. Once that is done, I'll catch the tip of the haptic and pull out. Okay? So far so good. Now watch. I tuck this haptic inside. This is the handshake technique again. Catch the tip of the haptic. Once the tip of the haptic is caught, so far so good, externalized. Now what do? Tuck the haptic inside that pocket. This is the Charrier's pocket. Once that's done, now I do the photopuplasty. Okay? Now you all know this game very well. So now I will do the photopuplasty. I've done it from one side. Now remember, I told you before, there were peripheral anterior synechia on that side. Please understand, as long as I have those peripheral anterior synechia, I'll obviously have to do PDEC in that case. You know the endothelial decompensation. I need an air bubble fully. It will not happen because there is a peripheral anterior synechia. I need to break those peripheral anterior synechia. So what am I going to do now is this. I'm going to break those synechia. Here I've purposely created an iodialysis. This is purposely created because I need to break that synechia. Now remember, I've already shown you how to do the trocar assisted iodialysis. So you see, opposite the iodialysis, I'll fix the trocar. Now I will pass the double arm Prolene needle. So now I'm sure all of you know this game very well. Pass it, bring it out. Now I'll take the second arm, pass it, bring it out. Okay? Now from the other side, I pass the 30 gauge needle, so I railroad. Now all you need to do is pull. Once you pull, watch what's happening to the pupil. It will get distorted. You know it's going to happen. Okay? It will get off-centered. So you will do a two-fold technique. In other words, I will now do a photopuplasty. Now look, my pupil is bang on track. My Purkinje image is bang on track. And at this stage, all I do is I shift to air. Now I take off my endothelium desmase complex and do the PDEC. And we have Dr. Namrata Sharma who's joined us right in time for this thing as the top corneal surgeon, one of the best in the world. Here we can see we are now taking this graft, preparing it, injecting it inside. Once inside, I will unroll it and make it all right. Now, you know, ladies and gentlemen, at this stage, oh, I was on cloud 7. If there's some other clouds above that, I was on that cloud also. Okay? So I was so happy. Now I saw the patient post-op day 1. Yeah! So I told my wife, see, super surgery. Now I saw the patient, then 1 week post-op, counting finger 4 meter. So my wife saw it and comes to my room and says, what is super surgery? This is called stupid surgery. I said, hello, I did everything. Patient not seeing, she told me. How will this patient go back to Iraq? Can you believe what I did? I couldn't believe it. Ladies and gentlemen, I had messed up in the IOL power calculation. Oh, believe me, there is no deeper hole I can go into. I'm wondering which hole can I dig myself inside and go into. So now let me ask Namrata, help me. Patient has come from Iraq. What do I do? I've done everything in the world in that case. Okay, now IOL power calculation. I can't do LASIK. The cornea is not that thick enough. It's -10. Look, basic mistake. Phakic IOL patient. Obviously it has to be a myopic patient, correct? How could I be not that smart? Or why was I that dumb that I should have realized I'm going to put a 10 or 8 or something? I remember I asked the patient, what is the lens of power? And they told me 20, and I just blindly put it inside, you know, without seeing it. So Namrata, you see the mess which I've got into. I can't do LASIK. I can't do SMILE. The power is too much. There is a problem of visas, a hotel stay. So what I said is, can I go back again? Remember, ladies and gentlemen, I've done a PDEC 1 week. This is -10, 6, 18. Okay? So now what I do is, I take the patient back to the OR. Again, break all the pinhole pupils which I've created. You can see that. take off the glued IOL portion. Now I'm making a scleral tunnel. Now I'm damn scared because there is an endothelial graft inside, and this is just 1 week post-op. Okay? Now through the scleral tunnel, I explant that IOL, and you can see that coming out there. Once that's done, I take the correct power IOL. Again, I do the glued IOL. Again, I do my handshake technique. Again, I'll create tucking of the Chariot's pocket and fix it inside. Now remember, after vitrectomy, again I have to do the pupilloplasty, don't forget. So now you see I'm again doing the pupilloplasty, 4th row. Now watch on the other side when I'm doing. And this is when my heart attack increased more, because you will see here, look at that graft. Oh, I was very scared. Okay, I said, listen, don't try your luck more than what you are into now. I just closed it up, and I thought this small rim of iris tissue there, you see, I will just knock off in a second and clear it off. Now you can see again P1, and you can see very clearly P4. Focus on the P1 only. Now remember, my graft is still attached, and that's one of the beauties of PDEC. You see, this is 1 week post-op, ladies and gentlemen. See how the patient behaved post-op 6-12. So you can see pre-op, PL, 1 week post-op, counting finger 4 meter. We did the phakic IOL explantation, glued IOL, pinhole pupillasty, PDEC, IOL power calculation mistake, glued IOL exchange, and 4th row pupiloplasty. Namrata, comments from you, please.
So I think that was a wonderful case. I mean, very complicated case. I shouldn't say wonderful case, but managed wonderfully. And only Amar, you can do it because you are capable of doing all those techniques. Even exchange of glued IOL, I think exchange of glued IOL is a very difficult thing to do. But in your hands, everything seems to work. And pinhole pupilloplasty, I think that is something we as cornea surgeons have not explored too much because we like to tackle disease on the cornea itself. But then there are situations when you have extreme ectasias and when you do corneal transplant surgeries, you might still get astigmatism in them or cylinder in them, which could be high. So I think in all those cases, it makes sense to do pinhole pupilloplasty.
Thank you very much, Namrata. Now let's look at this last case, and then I'll shift it to Namrata to speak. And in the morning, actually, I got an email, you know, from Ashwin, where they've been invited by American Academy Cornea Subday to talk on this particular topic, which I'm going to talk on, and that is, as Namrata said, pinhole pupillasty for corneal scarring. Now, there are patients like this, in which invariably anyone will say, let's do a PK. Now we are moving on to a new system. I was using pinhole pupillasty mainly for astigmatism, high HOAs and RKs and all those type of cases. We started using for cases where we can avoid a penetrating keratoplasty. This was a young boy, 14-year-old boy, who came to me from UP. He had a knife injury. The previous surgeon had operated him, and you can see how the case looks. Now, patient was referred to me for PK, and when I saw the patient, I saw here, look at the HOA. That's about 4.7. A normal HOA should be 0.3. Okay, astigmatism is very high. So I said, okay, let me see what we can do for this patient. The patient has a large white to white of about 12 millimeters. Remember that. And now, this is the trick which I want to teach everyone here, and I talked to you about before. When you have a large eye, wherever the flaps are, make a small iridectomy. So when you make a small iridectomy there, the idea is you can come more anterior. You go through the iridectomy, so what happens is the iris damage will not occur. Now you catch, there's a subluxed IOL. I am going to bring this up anteriorly, do my vitrectomy before this lens falls down. Once that's done, now my question is, obviously I have to explant this IOL, it's a one piece. Question is, how do I explant an IOL? If I cut, the chances of the IOL falling down are there. So what am I going to do? I'm going to first do a glued IOL. So watch what I'm going to do. I made my second sclerotomy on the other side. Now I am going to do a glued IOL behind the existing IOL. So here you see me doing that just now. I'll take a 3-piece IOL. Now remember, the media is hazy because of the corneal opacity. I'm catching that haptic, externalizing it. Now I'll do the handshake technique again behind the existing IOL. You can see that. My assistant is using an endolimiter from outside, catching the haptic, pulling it out. Once both haptics are out, look at the amount of haptic externalized. See the amount of haptic externalized, a lot. Remember, this was a large eye, 12 millimeter eye. Still, I have a lot of haptic externalized. The reason is very simple. I came more anterior. So all of you, when you're doing a glued IOL, please make a small iridectomy, come more anteriorly, and you'll be very safe. Now create the chariot's pocket and tuck it in. So far, so good. Now the next step for me to go in is, obviously, once that is done, I have to cut the existing 1-piece foldable IOL. So I take a scissor and I cut. I have no fear of this IOL falling down because nowhere it can go. My IOL support is there. In other words, ladies and gentlemen, I have created my own posterior capsule. Once that's done, I start the photoreoplasty. What is the aim? Please understand. My aim is very simple. I am going to create a pinhole pupil. Remember one thing, if a patient has got, let's say, 10 diopters, 20 diopters, it does not matter to me because I am not correcting his astigmatism. Pre-op, post-op is same. I have neutralized his astigmatism. Whatever is HOA, let it be. I've neutralized it. So I'll keep on doing the photoreoplasty till I get a small pupil. You see, that's an iatrogenic iridectomy which enlarged. Perhaps when I did the iridectomy, it became too big. I will close that also if needed. That's not a story. I can keep on doing it. My idea is trying to miss that central scar. Remember, my aim is very simple. I want to prevent or avoid a penetrating keratoplasty. So you can see now, catching that thing, bringing it out, putting the 4 throws inside, sealing that everything down. So once you do this meticulously, one by one, and I'm always using an endometer from outside, and I think that trick was taught to me by Susan. I have to give credit to Priya Narang for helping me and doing pioneering work on the photoreoplasty, on the reverse 4 throws, and all the other techniques. Now you see I'm closing even that iatrogenic iridectomy, which by mistake I had created, because I don't want this patient to have any diplopia, things like that. Now take a vitrectomy probe. I'm just enlarging it a little bit. Remember, if you don't have a vitrectomy machine, you don't worry. Your phaco machines have existing vitrectomy machines which are very good. So you don't have anything to worry about. Here you can see now I'm missing that scar a bit. Look at that Purkinje image also is pretty good there. Now all I need to do is seal everything down, and once that's done, you see I'm applying the glue, sealing everything down. See how the case closes, and this is the surgical step that I'm showing you. Let's see the patient. Remember, patient has come to me from UP, young boy. They are 6'9", N6. So he has distance and near without glasses. So I'll ask Rohit to comment while Namrata, if you fix up your... You're going? Okay. So Namrata comments on pinhole pupiloplasty.
So by the look of it, if you see the pre-op patient, again, like cornea surgeons would think would be a corneal transplant. But I think with pinhole pupiloplasty, what is taken care of is also a little bit of irregular astigmatism apart from regular astigmatism, because only that central 3 millimeters is the part, you know, which is affected. But I just want to ask you one question. Suppose, because this is post-traumatic, suppose this patient has a problem in the posterior segment at a later date, then would this pupil dilate, or would you have to redo it for it to dilate?
I'll just tell you about this in a second. So the question basically is, what will happen if by chance, let's say post-operatively, first of all, can you see the fundus in these patients? The answer is yes, even through 1.5 millimeter pupil, okay? The reason is very simple. How do we see them? You have the scanning laser ophthalmoscope. So you have the Nidec Mirante, you have the Optos, the Heidelberg, and the Zeiss. But let's say, theoretically, 5 years later, the patient develops a detachment. All you do is take a YAG laser, shoot, and you're bang